So hello everyone, we are back again with our MCQs. So let's begin with the first MCQ. So the first MCQ is the broadband area for primary motor area language. So so what we are discussing here is, so the first area is the broadband area for primary motor area is, the options here are 4, second option is 1, 2, 3, then third is 5, 7, and the fourth is 16 or 18. So I repeat the question, it is anatomy question. So it is Brodmann's area for primary motor area is, the options are 4, 1, 2, 3, 5, 7 or 16 or 18. So it's a factual question. So if anyone knows the answer, can tell. The Brodmann area is, Brodmann's area for primary motor area is, third, 5 and 7 is not the answer, no. The answer here is, the answer is 4th. You have to remember this. No other option for this. Okay, next question we have, it is an ENT question. See, a middle-aged patient comes to you with recurrent episodes of whirling vertigo, then which usually are preceded by a variable sense of ear pressure and fullness, decrease in hearing, and a low-tone urine tinnitus. So which of the following is a useful test to diagnose this patient's condition? And the options here are autoacoustic emission, Lisser test, caloric test, and dip Hall PK test. So basically, patient is there who comes to you with a whirling vertigo, and he has, before the vertigo, presents with you with ear pressure and fullness, decreased hearing is there, and low tone tinnitus is there. So first, do not diagnosis. Because without a diagnosis, you won't be able to tell what is the investigation choice here. And the options what I told is autoacoustic emission, Lisser test, caloric test, and deep Hall PK test. So if anyone wants to answer this. Okay, the answer here is, see, first the diagnosis which it is there, it is a Meniere's disease, because all the condition whatever it is given, that is a vertigo or sense of ear pressure and fullness, will be seen in vertigo. So in vertigo, the diagnosis, that is investigation choice is Lisser test. Others are also there, like see, caloric test can be diagnostic, but it is not actually the specific test for Meniere's disease. So the specific test for Meniere's is glycerol. And why glycerol? See, glycerol is the osmotic diuretic. So when you give osmotic diuretic in Meniere's, it will reduce the pressure inside the ear. So you will find relief in that. So in that way, the glycerol test is the specific test for Meniere's disease. And what they have given is caloric test is not diagnostic, as it is abnormal in many other conditions like ototoxicity, vestibular schwannoma, vestibular neuritis, etc. And deep Hall PK test, what it was given, it is used for diagnosing BPPV, not used here. Okay, next question we have. 43-year-old man working in a mining industry presents with painful paresthesia of his hands and feet. Examination of the limbs reveals the following findings. Which of the following is a drug of choice for chelation in this condition? So the options are penicillamine, succimer, calcium disodium EDTA, or disodium edetate. So see, they have given an image here. So basically the image, I cannot show you, but it is, see, the image here is suggestive of a raindrop pigmentation. So just tell me where you will see the raindrop pigmentation. Raindrop pigmentation is seen in which of the conditions? Then you can tell the answer. I will repeat the question. A 43-year-old patient comes to you with, he is working in a mining industry. So that's the point. Mining industry is working, and he has a painful paresthesia in his hands and feet. Examination of the limb reveals the following finding, that the finding is the raindrop pigmentation all over the limbs are there, and which of the following is a drug of choice for chelation of this condition. So the options are penicillamine, succimer, calcium disodium EDTA, or disodium edetate. So basically it's a case of poisoning. So anyone can tell what is the poisoning, which poison it is. Because here we are using a chelation therapy for which poisoning. Okay, I will only tell. See, the first diagnosis is here is a chronic arsenic poisoning, because you can see it is a mining industry, is working mining industry and all that, and raindrop pigmentation is suggestive of arsenic poisoning. So what we use here is succimer, that is the second option is the right option. Succimer is the drug of choice for chronic arsenic poisoning. Anything else they haven't seen. See what you can do for okay, this is a case of chronic. For acute you can use BAL, BL, DMSA or DMPS. And for chronic what the question is, it is Satsimar. Next question. 55-year-old woman comes to you with abdominal pain and constipation. You do a barium enema and it reveals a apple core sign. In which part of the colon is such a growth commonly seen? The options are left colon, right colon, transverse colon or cecum. So 55-year-old, abdominal pain, constipation, barium enema shows apple core sign. Which part of the colon is seen? Basically it is growth commonly seen in left colon, right colon, transverse colon or cecum. Anyone like to answer this? It's a colon cancer, but which I will tell which type of colon cancer it is. See, apple core sign is basically it is seen as a consistent type of cancer. That is, it is most common in the left side. Ulcerative type is more common on the right. So basically, it is a consistent type of colon. A. Yeah, A is the right answer. Left colon is the right answer because it is a consistent type and it is seen in apple core sign. And ulcerative type is seen in the right side. And here they have given, see, the most patients with left-sided colon cancer often present with increasing constipation, while the patient with right-sided cancer often presents with melena and fatigue associated with anemia. Okay. Next we have, what is the most common presenting feature in a patient with right-sided colon cancer? Yeah, I just said, I think. See, diarrhea, anemia, constipation, and abdominal pain. So what is the most common presenting feature in patient with right-sided colon cancer? Right side is also the ulcerative type, so it is the options are diarrhea, anemia, constipation and abdominal pain. I just said the answer before only. If anyone can recall most common presenting feature of right-sided colon cancer. See, melena was there, fatigue was there, abdominal pain was there. So what? One more. Okay, the answer here is anemia. And anemia is the most common presenting feature in right-sided colon cancer. And it mainly presents with altered bowel and all that. Okay, that you know. D not the answer. Anemia. Abdominal pain is not that. It is a feature, but it is not most common presenting feature. Then next question we have. You are asked to do a thoracocentesis for a patient with child pleural effusion. Sorry, with a mild pleural effusion on the left side. You are being cautious by inserting a needle into the left mid-axillary line of the patient. You would not insert the needle below which level so that you are not to damage the surrounding structures. And the options are 6th rib, 10th rib, 8th rib, 12th rib. So basically you can tell you are an intern and you are doing a thoracocentesis for a person, and when you do a thoracocentesis for a mild pleural effusion on the left side, and basically at what level you will do so that you don't injure the surrounding structure. 6, 10, 8 or 12th rib. This you might have done in pleural effusion tapping. Anyone wants to answer 6th rib, 10th rib, 8th rib or 12th rib? We don't do so that it doesn't damage the surrounding structure. In intensive we have been taught while pleural tapping also which rib we do. If I will tell the answer here is 10th rib. The inferior margin of the pleura that too in the mid-axillary line at the level of 10th rib. So that you would not go below this level. It is done in 8 or 9 intercostal space so that not to damage surrounding structures. So in which you will not insert, that is the 10th, 6, 8 and 8 you can do. Okay, next question. Then which of the following is not a virulence factor for Nishiya gonorrhea? The options are M protein, outer membrane proteins, IgA protease or pili. So which is not a virulence factor for Nishiya gonorrhea? M protein, outer membrane protein, IgA protease or pili. Which you have to remember. I also have to remember. See, M protein. The answer is M protein here. M protein is not a virulence factor for Nishiya. Others like IgA protease, pili, outer membrane proteins are the virulence factor for Nishiya gonorrhea. And see, M protein is a virulence factor for Streptococcus pyogenes. So this all you have to remember, that for gonococci you have outer membrane proteins, IgA protease, pili, lipo-oligosaccharide, aspirin, lactoferrin binding proteins. Okay, next question. See, the glucose transporter specific to the transport of fructose from the intestine to enterocytes is. So tell me the glucose transporter at the LUT1, LUT2 and all that, which is glucose transporter to the specific to the transport of fructose from the intestine to the enterocytes. So the options are LUT1, 3, 5 or 7. So anyone would like to answer this? Which glucose transporter specific to the transport of fructose from the intestine to the enterocytes? Okay, the answer here is LUT5. See, LUT5 is basically it is present in the small intestine, testis and sperm. So LUT5 is present in small intestine, testis and sperm, and its primary transport is the fructose. So this you have to remember all that. LUT1 to see, LUT1 is present in brain, RBC, placenta. LUT2 liver, LUT3 neurons, and LUT8 is blastocytes, and this what LUT5 is that for small intestine, testis and sperm. Next question we have P3 woman. P3 woman bleeds profusely after delivery of the placenta, and then you initiate a oxytocin infusion. The patient continues to bleed and the uterus fails to contract despite bimanual compression. Then she becomes tachycardic and hypotensive. So what is the next best step for her management? So the options are tight intrauterine packing with gauze, balloon tamponade, ligation of uterine arteries, or hysterectomy. It's usually emergency case, that is after delivery of the placenta she bleeds, that is a postpartum maternal. She is bleeding profusely and you initiate oxytocin but doesn't help. She continues to bleed and the uterus fails to contract despite you do your bimanual compression also, it doesn't contract. So and it becomes tachycardic and hypotensive. So what is the next best step? So it is tight intrauterine packing with gauze, balloon tamponade, ligation of uterine artery, or hysterectomy. Now I would like to answer this which it's OBG. So okay, I'll tell the answer. The answer is balloon tamponade. So others are like tight uterine and all that we don't do. We do a balloon tamponade. And what is the case? It is a case of atonic PPH, because the uterus was not contracting, there is no tone in the uterus itself. So that's why it is non-responsive to medical and bimanual. Okay. See, options which I told you first was tight intrauterine packing with gauze. So in that it has become unpopular due to the dangers of it is bleeding and infection of present, so it is not popular nowadays. Then the intrauterine artery ligation is done when tamponade fails. The tamponade fails, then we do ligation. And hysterectomy is the last option. If nothing works, we have to do hysterectomy. And then next question we have the distinguishing features between the hyperglycemic, hyperosmolar state and diabetic ketoacidosis include all of the following except ketosis, anion gap, hypotension or arterial PCO2. So I will repeat the question once. What is the distinguishing feature between the hyperglycemic, hyperosmolar state and diabetic ketoacidosis? Include all of the following except ketosis, anion gap, hypotension, arterial PCO2. This I think you might tell. It's an easy question. How will you differentiate hyperglycemic, hyperosmolar state with diabetic ketoacidosis? Except ketosis, anion gap, hypotension, arterial PCO2. Anyone? Okay. See, in both HHS and as well as DK, what are the first symptoms what you will see? So the patient with DK comes first, the BP will fall. It is a hypo, basically it's the glucose will be less. But what you will see is hypotension and tachycardia, the common features in both. So the answer here is hypotension, because see, ketosis, anion gap and arterial PCO2 will be different in both the conditions. No, anion gap will be No, it is hypotension only. Because hypotension will be seen in both the conditions, in HHA as well as DKA. And what you were telling is that is the anion gap. Anion gap will create a difference. Anion gap will be increasing in DKA, whereas it will be normal or slightly increasing in the HHS. So here it is hypotension. Next question we have: a 23-year-old pregnant woman comes to you at 11 weeks of gestation period and was diagnosed with falciparum malaria. So what is the drug of choice? Quinine, artemisinin-based combination therapy, chloroquine or primaquine? So 23-year-old woman with 11 weeks of gestation period with falciparum malaria. What is the drug of choice? Quinine, artemisinin-based combination therapy, chloroquine, primaquine. Basically, which is not teratogenic in pregnancy. So the options are quinine, artemisinin-based combination therapy, chloroquine or primaquine. Anyone wants to tell this answer? Okay, see. Here the answer is quinine, because quinine is the drug of choice for the first trimester. It is only 11 weeks of gestation period. So for the first trimester we will give quinine itself. And for second and third, you can give artemisinin-based combination therapy. So you have to remember this. For first trimester we give quinine, and for second to third trimester it is ACT, that is on combination therapy. And we don't give chloroquine, primaquine because of its teratogenic effects. Next question: 67-year-old man presents with fatigue and weight loss. On examination, pallor and splenomegaly were noted. Then peripheral blood smear examination you do, and it shows the image. And which of the following BCR ABL tyrosine kinase inhibitor is not a first-line agent for this condition? Because repeat the question: 67-year-old is there with fatigue and weight loss. Examination, pallor, splenomegaly present. Then the peripheral smear image they have given, and see the peripheral smear, what I can see is, see the WBCs are increased, WBCs are more, and activate precursor forms are there, that is the myelocyte, metamyelocyte and all that are there. Okay, and blast cell is important. Okay, so which of the following BCR ABL tyrosine kinase inhibitor is not a first line agent for this condition? The options are imatinib, dasatinib, nilotinib, bosutinib. So first tell me what is the diagnosis for this condition? Anyone? See, for it is a BCR ABL tyrosine inhibitor. Okay, the answer here is bosutinib. This I also didn't know. Okay, for diagnosis you can tell that it is a CML. Why? Because the peripheral smear, what I told, at the WBC is increased, myelocyte is there, metamyelocyte is there, band forms are there, which suggests you CML. And bosutinib is approved for the use of this condition only for resistant or intolerant cases and not for newly diagnosed cases. Okay, because it is already a history, long history is given. Fatigue, weight loss, yeah. And agents that can be used as the first line for CML are imatinib, dasatinib, nilotinib. But for resistant and intolerant cases we give bosutinib. Which of the following BCR ABL tyrosine is not a first line? It is not a first, bosutinib is not a first line. So imatinib, dasatinib and nilotinib can be given. Next question we have: see, which of the following is the most common clinical presentation of retinoblastoma? The options are leukocoria plus heterochromia iridis, leukocoria plus pseudohypophyton, leukocoria plus hyphema, leukocoria plus strabismus. So which of the following is the most common clinical presentation of retinoblastoma? Anyone wants to tell the answer? The options I will repeat once again: leukocoria plus heterochromia iridis, leukocoria plus pseudohypophyton, leukocoria plus hyphema, leukocoria plus strabismus. Leukocoria is there in every option. Which leukocoria? Leukocoria plus what? Heterochromia iridis, pseudohypophyton, hyphema or strabismus? Most common clinical presentation of retinoblastoma. What I will tell the answer here. The answer is the fourth option, that is the leukocoria plus strabismus. It is the most common clinical presentation for retinoblastoma. So retinoblastoma, you might know, it's basically it's a tumor of eye only. So what are the features, clinical features? Its presence within the first 2 years of life, congenital, and leukocoria, strabismus, painful red eye, secondary glaucoma, orbital inflammation will be there, then orbital invasion or visible extraocular growth will be there, and metastasis will be there. Okay. See, what are the investigations we will do in this? It is the 3 investigations what we have given. It is the red reflex testing with direct ophthalmoscope. It is simple screening test for leukocoria. Dilated fundus examination using the indirect ophthalmoscope, and MRI of the orbit and brain is the investigation of choice. So the answer is leukocoria plus strabismus. Next question: which among the following is not a feature of reversible cell injury? The options are large amorphous densities in the mitochondria, decrease in ATP generation, formation of bleps in the plasma membrane, and detachment of ribosomes from granular endoplasmic reticulum. So which of the following is not a feature of reversible cell injury? Not a feature. Good. Okay, the options are large amorphous densities in the mitochondria, decrease in ATP generation, formation of bleps in the plasma membrane, and detachment of ribosomes from the granular endoplasmic reticulum. Anyone? Which is not a feature of reversible injury? See, reversible injury, that means that you are asking for a reversible injury. So which among is not a feature of which among is a reversible cell injury? So the answer here is there is a large amorphous densities in the mitochondria, which is a irreversible injury. Otherwise, what the options they are given, that is decrease in ATP generation or formation of bleps in the plasma membrane, detachment of ribosomes from granular endoplasmic reticulum. They all are basically reversible cell injury. So this you have to remember, what are the reversible cell injuries and what are the non-reversible cell injuries. This, okay. Next question. When a comatose patient comes to you who has been shifted to the cardiac ICU after achieving a return of spontaneous circulation, what is the body temperature to be maintained in this patient? 12 to 16 degree, 20 to 24 degree, 32 to 36 degree, or 42 to 45 degree. So basically it is a comatose patient who has been recovered, has been shifted to the cardiac ICU after achieving normal spontaneous circulation. So what is the body temperature? 12 to 16 degree to be maintained. 12 to 16, 20 to 24, 32 to 36, 42 to 45 degree. So anyone wants to try at least. What is the target temperature to be maintained for a constant? Okay, the answer here is 32 to 36 degree. Yeah, at least for 24 hours you have to manage the patient with on this target temperature, that is 32 to 36 degree. So why it is done? See, this is done in post-cardiac, all are days, but still comatose, all at one time. Okay. So the entire body is to be cooled using a combination of fluid like blankets and all that. Okay, the main thing you have to remember is 32 to 36 degree you have to maintain when the patient comes from ROSC. Now you have to calculate this. Calculate the maintenance dose for a drug M with 100% oral bioavailability, which meets the target concentration of 2 mg per liter and clearance is 20 liter per hour. And what is the dose? It is Q18, that is 4 times a day. So the options are 300 mg, 160 mg, 250 mg and 240 mg. This is the biochemical. You need to know the formula for maintaining dose here. Otherwise you won't be able to tell. See, I will tell the formula at least if you don't know the answer here they have given is 240 mg, but the formula at least you have to remember is it is a target plasma concentration into clearance into dosing interval by bioavailability. So yeah, it is that target was how much? It was 2 into clearance is 20, 2 into 20 into sets, that is the dosing interval they have given. It is QID, sorry, it is not TID. QID is sets. 2 into sets for bioavailability is that is 1 because 100% is there, that is 1. So the answer is 240. 2ID correspond to 4 times per day, hence the dosing interval is 24 by 4, that is 6 hours. On that way they are given. Dosing interval is basically in terms of hours. Therefore QID is 4 times a day, that is 6 hours in a dosing interval. Next question, we have a group of public health workers is trying to identify glaucoma. So it is a glaucoma case at an ophthalmology camp. So which of the following is the best index to assess for glaucoma inflammation? The options here are follicles on the upper tarsal conjunctiva. Second is limbal follicles and the Herbert pits, presence of trichiasis and enteropion, and the last one is vascular pannus and the superior limbus. So basically the cases of a glaucoma, and what you have to tell you what is the best index to assess the inflammation of glaucoma. I will repeat the options: follicles on the upper tarsal conjunctiva, limbal follicles and Herbert pits, presence of trichiasis and enteropion, and vascular pannus and the superior limbus. Can anyone try this question? Okay, the answer here is it is the follicles on the upper tarsal conjunctiva. See, in a patient with glaucoma, if it is an inflammation, so in epidemiological study, that is basically not at optional question, it is a PSM question. So epidemiological studies, you have to see upper tarsal conjunctiva. This is the best index for glaucoma inflammation in the eye. But for ophthalmology, you can see there are any two of the following diagnostic: trichiasis. Trichiasis is there. Yeah. So for diagnostic criteria, there is any two of the following should be there. See, first, I'm telling for glaucoma, what is the diagnostic criteria? So any two should be present. First is follicles on the upper tarsal conjunctiva, limbal follicles and Herbert pits, typical conjunctival scarring, that is trichiasis and enteropion, and vascular pannus most marked at the superior limbus. But for epidemiological studies, upper tarsal conjunctiva is the best index for glaucomatous inflammation. Yeah, good afternoon. So early. Okay. Next question we have here is, which of the following is the drug used in the treatment of tinea crudis, for which widespread resistance is found to be developing? The options are itaconazole, griseofulvin, terbinafine, and voriconazole. So I repeat, which of the following are drug used in the treatment of tinea crudis, for which widespread resistance is found to be developing? Itaconazole, griseofulvin, terbinafine, voriconazole. Anyone wants to answer this question? Just tell me what is the treatment of choice for this tinea crudis and corporalis both? C, terbinafine is the right answer. Terbinafine, the use of terbinafine as an agent of choice has been limited lately due to the development of resistance. So the answer is C. Next we have a 46-year-old woman comes to you with a sudden onset of chorea. Her father died of a neurodegenerative disease at the age of 56 years. So genetic evaluation we did and it reveals CAG repeats. So what is the mode of onset of this disease? Autosomal dominant, autosomal recessive, X-linked dominant, or X-linked recessive? So it's very simple. It's a genetic case. A 46-year-old comes to you with a sudden onset of chorea and father died of neurodegenerative disease and at the age of 56 years. So genetic investigation reveals CAG. So what is the autosomal dominant, recessive, or X-linked dominant, or X-linked recessive? First tell me what is the disease, because without knowing the disease you won't be able to tell what is dominant or recessive. Anyone? See, from the word chorea only I think you can get it. And that neurodegenerative disease genetic history is there. Anyone wants to tell you? Okay, the answer here is first one, that is so full answer I will tell what is the diagnosis. Diagnosis is Huntington's chorea, that is Huntington disease only, and it is autosomal dominant, that is the answer is A. So what is, it is also known as Huntington's chorea. which has an adult onset and associated with loss of specific subset of neurons in the basal ganglia and cortex. The characteristic feature what we see here is involuntary movements, dementia and behavioral changes. So three things we see in Hyperglycemia, that is involuntary movements, dementia and behavioral changes. And it's autosomal dominant. Just remember that it is autosomal dominant. Next we have, in which of the following patients would you administer Covishield vaccination? This I think everyone will tell. I will repeat, in which of the following patients would you administer Covishield vaccination? Number 1, a 51-year-old who underwent hematopoietic stem cell transplantation 5 weeks ago for aplastic anemia. Second, a 60-year-old man with a history of type B diabetic mellitus. 32-year-old who received TT immunization 20 days back following a trivial fall from the bike. Or a 45-year-old man on dialysis 3 times a week for CKD. Or a 40-year-old woman on insulin therapy for type 2 diabetic mellitus. It's a long question. And the options are like this, it is 1 to 3, 1 to 3, 4, 5 and all that. Okay. I'll repeating only it will be good. Okay, in which of the following patients would you administer Covishield? And see, first let us know which of the following you won't be able to administer that. And the answer here is only the first one, that is a 51-year-old man who underwent hematopoietic stem cell transplantation 5 weeks ago for aplastic anemia. So anyone just tell me why you cannot give a Covishield vaccination in a transplant like this, hematopoietic stem cell transplantation? Because other all options we can give, at diabetes or whatever, TT immunization, CKD and all we can give Covishield, but why we cannot give an hematopoietic cell transplantation? So I think okay, if it is a immunosuppressive, yeah, because in transplant already you are given immunosuppressive drugs. So basically, if you have an immunosuppressive therapy itself, you cannot give a Covishield vaccine because it won't affect only. There is no use. An additional risk factor also will be there with the COVID-19 complication. So you cannot give with a transplant patient. Okay. So next question we have, a middle-aged woman is there who presents with difficulty in swallowing both solids and liquids. Then a barium swallow revealed the following findings. There is one image. From the image only I can tell. See. Okay, I will tell. See. Okay, just tell me bird beak appearance is seen in which of the condition in the barium bill. All others are okay. It is difficulty in swallowing both solids and liquid, but barium bill has bird's beak appearance. So options are achalasia cardia, diffuse esophageal spasm, esophageal carcinoma, or Jenkins diverticulum. This time anyone can tell. Bird's beak appearance in barium bill. Okay, you don't want to tell. Okay, no problem. The answer here is achalasia cardia. In achalasia cardia, bird's beak appearance is seen. One more was there, rat tail appearance. Rat tail appearance is in which of the condition? Yeah, achalasia cardia. Rat tail appearance, if anyone knows, rat tail appearance is seen in which of the condition? So rat tail was seen in carcinoma. Rat tail is seen in carcinoma. Achalasia cardia, you might be knowing, it is the loss of ganglion cells within the esophageal minor plexus. No need to tell all that. It is a dysphagia. It is for both solid and liquid. For carcinoma, I think it is dysphagia for only it is solid and then liquid. And in achalasia, it is both solid and liquid. Okay, this next question we can go. While examining a pregnant woman, you measure her fundal height to be 32 cm and the station of fetal head is at -2. So what could be the probable weight of the fetus? 2.3 kg, 3.5 kg, 3.1 kg or 4 kg. I will repeat. When you examine a pregnant woman and you measure the fundal height 32 cm it is, and the station of fetal head is at -2, what is the probable weight of the fetus? 2.3, 3.5, 3.1 or 4? Just think and tell. That's a formula, Johnson's formula. Anyone knows the Johnson's formula? See, height is 32, station is -2. Okay, I will tell the answer. The answer here is 3.1 kg. See why 3.1? The formula only you have to tell. See, for Johnson formula it is right 32 minus 12 into 155. That is 3.1 kg. Okay, the formula I will repeat once again. It's the height of the uterus above the pubic symphysis minus 11 into 155 grams. So you have to see if the station is above or below. If the station of head is below the level of ischial spine, the formula is this, that is the height of the uterus minus 11 into 155 grams. But if it is above the level of ischial spine, the formula changes, that is the height of the uterus above the pubic symphysis minus 12, not minus 11 into 155 grams. So by this it is calculation is 3.1 kg. Next question we have, it's 16-month-old boy is found to have a weight of 8 kg. His weight for age are plotted on a WHO growth chart. What advice would be appropriate? So I cannot show you the growth chart actually. Okay, I'll just tell you in the growth chart one thing that, see, the child falls in between -2 to -3 SD. So what did it suggest? I will again repeat, 16 month and 8 kg weight. And on weight for age in the growth chart, you can see it between -2 to -3 SD. So what is the advice? What advice is most appropriate? First tell me what is it. The options are no malnutrition, mild, severe or moderate. First tell me which malnutrition it is, which malnutrition it is there. Moderate, severe or mild or no. Anyone can tell me -2 to -3 SD. Which malnutrition is present? Okay, the answer is it's a moderate type of malnutrition. So in moderate type of malnutrition, yeah, you will teach the mother how to feed. If it is, suppose it's moderate, yeah, it's a moderate type of malnutrition. See, for no malnutrition, you have to do nothing basically. For mild, you have to give a home treatment. For severe, you have to tell the mother only to take the child to refer to the nutrition rehabilitation center. And for moderate, you have to teach the mother how to feed. So next question. 30-year-old female was brought to the hospital with complaints of recurrent episodes of acute onset breathlessness, palpitation, sweating, dizziness for the past 2 months. Physical examination and laboratory investigations were normal. Then which of the following is the drug of choice in the treatment of this condition? The options are SSRIs, benzodiazepine, monoamine oxidase inhibitor or buspirone. So 30-year-old, recurrent episodes of acute onset breathlessness, palpitation, sweating, dizziness for past 2 months. Physical examination and investigations are all normal. So which of the following is the drug of choice in the treatment of this condition? So the options are SSRI, benzodiazepine, monoamine oxidase inhibitor or buspirone. Anyone can tell? Because physical examination and laboratory are all normal. So this is a psychiatric question, and in that, when a patient comes to you, that is a recurrent episode is there. See, recurrent episode is there, that too breathless, palpitation, dizziness, sweating for the past 2 months, and if there is no investigation or nothing is there in the examination, we will consider it as a panic attack, panic disorder, and we give a SSRI because SSRI is the treatment of choice. Benzodiazepine we don't give. We give SSRI. SSRI is the investigation of what actually. It's a drug of choice. SSRI is the drug of choice for this panic disorder. And second line are TCA and MAO inhibitors. Benzodiazepine can be given, but it is used in an acute attack of panic disorder. It's not an acute. It's complaints of recurrent episodes of acute onset, but only in acute attacks. When the patient comes and then it is acute attack, then you can give benzodiazepine. Otherwise, it's SSRI only. Next question. Last question. Which of the following is false about the condition shown in the image below? So the image is of X-ray is of basically pelvis. And in the image of pelvis, and that too there is a fractured neck of femur. Yeah, it is a fracture of neck of femur. Okay. So you have to tell regarding the fractured neck of femur, which of the following is false. First, Malunion can happen if this condition is not treated. Second, the patient may be able to walk. Third, avascular necrosis is the most common complication, and the last one is shortening of the limb is less than 1 inch. So anyone can tell me what happens which is falls among this the neck of femur? Malunion, patient may be able to walk. Avascular necrosis is the most common, shortening of the limb less than 1 inch. At least get this question to the last question. So just tell me in fracture neck of femur there will be malunion or non-union? Because the neck of femur, if it is shorted or it is fractured, so it will lead to CD. Shortening of the limb is less than 1 inch. No, it's not false. See, shortening of the limb is less than. That is basically the question is asking what is false. Avascular necrosis. Yeah, that is not the answer. Tell me what is the false among this? Okay, in fracture neck of femur, avascular necrosis will be present. A is the answer, because malunion won't be there because it will be non-union, not malunion. So I will just tell the complication of fracture neck of femur at last. It is avascular necrosis, non-union, vascular necrosis of the femoral head, and which may lead to secondary osteoarthritis after many years. So yeah, we have completed the 25 MCQs. Okay, let's get it done. Okay, bye.